The RAAS system, how your body controls blood pressure and fluid balance. Imagine a sophisticated hormonal alarm system that activates whenever your blood pressure drops, your blood volume falls, or your kidneys detect low sodium. This system responds in seconds, raises blood pressure, retains fluid, and restores perfusion to vital organs. It is the renin-angiotensin-aldosterone system, the RAAS, and understanding it is fundamental to understanding hypertension, heart failure, kidney disease, and some of the most important drugs in medicine. Welcome to Medical Sciences Unfolded. Let's walk through the RAAS step by step.
Now let's look at why the RAAS matters in disease and pharmacology. In hypertension, the RAAS is often chronically overactivated, particularly in renovascular hypertension, where stenosis of the renal artery reduces perfusion and triggers continuous renin release. The result is relentless angiotensin II production and sodium retention, a perfect storm for resistant, life-threatening hypertension. In heart failure, reduced cardiac output activates the RAAS as compensation. Angiotensin II increases preload and afterload. Aldosterone causes salt and water retention, expanding blood volume. Initially helpful, this compensation becomes maladaptive. The overstretched, failing heart faces even greater resistance. This is why ACE inhibitors and ARBs are cornerstone therapies in heart failure. They interrupt this vicious cycle. In chronic kidney disease, RAAS activation accelerates glomerular damage by increasing intraglomerular pressure. ACE inhibitors reduce this pressure and slow disease progression independent of their blood pressure effect. Let's review the drug classes targeting the RAAS. ACE inhibitors such as lisinopril, enalapril, and ramipril block the conversion of angiotensin I to angiotensin II. They also prevent bradykinin breakdown, which causes the classic dry cough side effect and rarely angioedema. ARBs, angiotensin receptor blockers such as losartan, valsartan, and olmesartan, block the AT1 receptor directly. They do not affect bradykinin, so they are better tolerated in patients who develop cough on ACE inhibitors. Aldosterone antagonists, spironolactone and eplerenone, block aldosterone at the collecting duct. They are potassium-sparing diuretics used in heart failure, primary hyperaldosteronism, and resistant hypertension. Side effects include hyperkalemia and, for spironolactone, gynecomastia due to anti-androgen effects. Direct renin inhibitors like aliskiren block renin itself, the very first step. Though theoretically elegant, clinical trials have not shown additional benefit over ACE inhibitors or ARBs, and combination use increases adverse effects. The RAAS is not just a blood pressure regulator, it is a master controller of fluid homeostasis, renal function, and cardiovascular remodeling. Every time you prescribe an ACE inhibitor or spironolactone, you are reaching into this ancient hormonal axis and redirecting its output. That is the power of understanding physiology. Thank you for watching Medical Sciences Unfolded.